Welcome to the NeoFOCUS-UK Education Group webinar series.
Hi, everyone. It's a pleasure to introduce Dr. Ben Baucells, a neonatal consultant from the Centre Transport Service, who's trained in Barcelona as well as in Australia. He's currently working between neonatal services in Leicester as well as with the Centre Transport team. And he's the POCUS lead for neonatal services as well as transport services in his department. He's currently involved in research on the use of probiotics in the preterm infant and also in the study of neonatal hemodynamics and outcomes, as well as on the application of POCUS on the neonatal unit and in transport services. Thanks so much for your talk today, Ben. Really looking forward to learning from your current practice.
Thanks, Jean. It's a pleasure to be invited by the team. Great introduction from Jean. So today we're going to talk about the use of point-of-care ultrasound in transport. And first of all, I would like to say that I have an extreme passion for the use of point-of-care ultrasound, and I also have a big passion for transport, which I pretty much think that a lot of us have here, and that could be potentially a cause of conflict of interest or bias, but I do not have any conflict of interest to declare. So the objectives of today is to talk a bit about equipment, uses of ultrasound in transporting neonates, and I will try and combine it as well by reviewing protocols of emergency care that can be applied in transport. So what evidence have I used to base my recommendations, my explanations of today? So I've used part of the NeoFOCUS frameworks that we have here in the UK, and I have also relied on the guidelines produced by the ESPNIC. There's one that you probably will all be familiar with, and if not, I do encourage you to read it because it's quite thorough. And it was produced in 2020, and there's also been a new guideline released a month ago, I think now, about the use of quantitative lung ultrasound, which I also encourage people to look at. So I think the question that a lot of people sometimes have is, what are the practicalities? Is it safe to do point-of-care ultrasound in transport? What is the evidence out there? Unfortunately, we do not have a lot of evidence in transport in general, and then in point-of-care ultrasound focused in transport, there's even less. But we do know from some studies that in a short or a reasonable period of time, people that are ultrasound naive can be trained quite quickly, as this study points out that with an average of 8.6 hours, you're able to do an adequate assessment of cardiac function and a functional assessment to be able to guide your treatment. And I want to reiterate that what I'm going to try and talk about is point-of-care ultrasound. It's not the ultrasound that you do on your neonatal unit that you might be 20, 30 minutes, you are able to do the patient. It's you have a clinical question, you want to answer that clinical question, and you do 2-3 minute assessment to be able to get that answer. So having discussed that, I think that whenever you do transport, we are always obsessed with equipment. It's one of the big mantras of transporting. And there's a few things that we always need to take into account when we consider what kind of equipment would I want to use when I'm moving around in an ambulance to use for point-of-care ultrasound. So the first thing that comes to mind is durability. That system is going to be submitted to vibrations, sudden breaks. You might be in a crash. It might be bashed on a unit, you might arrive somewhere, you might not have a lot of surfaces, so you want to make sure that it's something that can withstand wear and tear. Obviously, you want it to be transportable, so you want it to be relatively lightweight, that it can be carried, and also that you're able to move it around different places and that you can take it with you. And it is also extremely important to have adequate storage for that equipment, because when you're traveling at 70 miles an hour, you don't want to have anything loose in the ambulance just to, if you can have an accident, it's not unheard of. There might be a sudden break, the baby might collapse and you might need to brake quickly. And you want to make sure that there's nothing that could constitute a hazard. So storage is, and being able to stow it away is very important. And you want to have reasonable image quality at the same time, because if not, when you're trying to scan, you will not be able to identify certain structures, and that's something that we'll talk about as well. And you want to be pretty much user-friendly. So ideally go for a machine that isn't too convoluted, that you can literally put there, press the button, and you have it available. Because one, you might have clinicians that may not have a lot of experiences in the use of ultrasound. And two, whilst you are stabilizing the baby, you might tell somebody, can you grab that thing there in the bag and just put it on for me so it's loading whilst I'm doing other things for this patient. So you want to make sure that people don't need to really think, how does that work? And the other thing that I always find very important is to have battery life. We might be moving a baby for 2, 3, even 4 hours. It's not unheard of. And if you need that machine, you want to make sure that you will have enough time to be able to use it in the ambulance, which hopefully you will not need it. But if you ever need it, you need to be able to have a good battery life. And the other thing as well is sometimes we consider, should I use all the probes in transport? Do I need all of these probes? And I would suggest that look at your needs, look at your skills of expertise in your clinicians or what your objectives are, and decide which of them. In my opinion, I would probably definitely have a linear hockey stick and a phased array, and probably a curved linear. To be honest, most hospitals will have it. We are neonates, we are not far away from a gynae unit, so they will have some sort of equipment that they can provide if you think that you need that probe. So having talked about all those aspects, we have different systems and different solutions available. And I'm not going to tell you which is the right one for your team or your needs. I'm going to talk a bit about briefly advantages and disadvantages of them. And I do think that you all need to consider, as I said before, what are the needs of your team? How are your transfers? What are the expertise that you have? So the first probes that we have are the handheld probes, which very transportable, very easy to move around, relatively easy to use. However, I do find that they have a very short battery life, around 20 minutes, and then they can overheat quite quickly. And the other thing is that usually to charge them, you need a docking station, which is maybe not ideal in the back of an ambulance where you can have something that isn't properly secured or stowed away. And the other thing as well is that they don't tend to be very durable. So if they are dropped on the floor, most likely that's the end of the probe, your ultrasound machine, and you'll need to purchase it again. On completely the other opposite side, we have the typical ultrasound machine that you have on the neonatal unit that's on wheels. So yes, it's quite transportable if you streamline it, you make sure that it isn't too bulky, and it has really good quality of image. You can have all the probes that you want of it. However, I don't see that fitting in the back of an ambulance, if I am honest, where you want to make sure that you can stow it away. And some of them have battery life, but they're not very resistant to vibrations and accelerations and decelerations. So probably I wouldn't advise that. What solution we went for is the middle one, which is a laptop style ultrasound machine. In this case, we went for the typical one that's military based. So it's very used to being bashed around, being in war zones, and has acceptable quality of image, has acceptable battery life, and it is relatively easy to use. And that's what kind of worked for us. But as I said before, just look at what your needs are and then take it from there. So having discussed the first mantra of transport, that is equipment, I think that now we should talk about when should I use point of care ultrasound in transporting children, neonates. And so essentially, when you have a sick baby and you're not really sure what's going on, you may want to scan that patient. You want to use it to diagnose or discard life-threatening situations, when you're considering whether that might change your management or the destination of that patient, and also prioritize treatments. In transport, we have something that's called the window of opportunity or the window of stability. So you have that patient that's become unstable, they've referred to you, you've just arrived, and you want to make sure that you do just the minimum necessary to have that patient stable enough to be able to take it to a neonatal unit that's going to or to their destiny, but you don't want to overdo things. So it is quite easy sometimes to get sidetracked and start doing a lot of interventions that you would do on the neonatal unit, but may not contribute to the stability of the patient on the transfer. And sometimes you can lose that window of opportunity, and then you will not be able to transfer that child that you would have been able to transfer before. when other methods are not available. So if you have a sudden desat at the back of an ambulance, you're not sure if there's a pneumothorax or not, it might be difficult to do a cold light. You definitely do not have an X-ray, so I would encourage at least to have something to be able to look, is there definitely a pneumothorax or not before you stop the ambulance, stabilize that patient, and put a needle drain in that situation. And it is advisable sometimes in long transfers when you want to make extra sure that you've checked for everything, and 2-3 hours, it will be a long time before you can reassess that baby potentially. So what are the benefits of using POCUS in transport? So it's real-time visualization and it is immediate. So the moment you put a probe on that patient, you get an image, and it's an image that will change depending on the patient and where you put that machine. And you will not be submitted to the delay that can sometimes happen of an hour, hour and a half to get an X-ray, because yes, they may come quickly, but in some places they don't have portable X-rays. Then you need to wait for it to be put on packs. Then you need to ask for a clinician to sign into it to be able to get it. So there might be quite a substantial delay by the time you've got the image that you wanted to get. And the other thing is that it's a non-radiating exam. We know that when admitted to a neonatal unit, patients can receive up to 120 X-rays at least, especially if you are an extreme preterm baby. And we don't really have a lot of evidence to tell us what is the true impact of all this radiation in the later future. What are the downsides? There is a risk of increasing your transport time. But as I said before, if you remember that this is a really quick assessment, you have a question you need to answer 2-3 minutes, to me doesn't seem an excessive amount of time. But it's easy sometimes for people to get sidetracked and say, oh, I want to do a full echo. I'll be 20-30 minutes doing it. And then this will really prolong that transport time. It does have a learning curve, but as I discussed before, there is some evidence out there that says that with a reasonable period of time, you might achieve reasonable skill in your clinicians. There is a risk of over-treating patients. So maybe that baby that was in 28% oxygen on the CPAP, you wouldn't have done an X-ray because it was relatively stable. And then you do a lung ultrasound, the lung score is really high, and you think, should I give Lisa? Should I intubate and give surfactant before I move? Because this baby could deteriorate if the transfer is an hour or two, whereas before you wouldn't have done that. And the other thing is that it's also observer dependent. So in some teams like ours, sometimes the consultant isn't present, and you will depend on what your team is telling you. But the solution can sometimes be video call or trying to get a bit of a better understanding of what's going on with that. So the question would be, what can I do with point of care ultrasound as anybody? So the question is directed to ourselves. And essentially, when we have a baby and we put an ultrasound machine on the baby, we can scan the brain, we can scan the heart, we can scan the lungs, we can scan the abdomen, and we can scan the vessels and other areas of the body. So essentially, you can do an assessment of a major organs in this patient, and you can have a really complete analysis if you would like it. So to try and make the session a bit more practical, I know that it's after 2 o'clock and all these things. So I've tried to create a few cases that we have actually encountered in transport where point of care ultrasound was actually a key aspect of that. So the first case that I would like to discuss is a term male infant, a couple of hours old, that's been referred to us from a special care unit, good weight, on a CPAP of 30% oxygen. SATs are maybe okay, but a bit suboptimal. They say that between the low 90s to high 80s, quite tachypneic actually, with a pH that's also a bit borderline, with a CO2 that's not quite right. So we dispatch a team to see exactly what's going on, and we get there. It was a unit that wasn't too far away. Some units can be up to 2 hours away for us, so in this case it was only an hour. When we got there, actually the baby had continued to deteriorate, was on a CPAP of 60% oxygen. SATs were still suboptimal, and they started to mention that there was pre-pro SATs different, and the baby was extremely tachypneic and recessing, had a really big work of breathing. So what we did was, okay, let's check the lungs to see what's going on there. And I do apologize because unfortunately we can't really export videos very effectively from our machine, so I'll need to rely a bit more on static images. But what we saw when we did a quick assessment of that lung is that on the right side, even right posterior, as you can see here, we don't only had A lines, There was no pleural sliding present. We didn't have any B lines. And when we put the M mode, you had this beautiful barcode. Whereas comparing to the left side, you do have a bit of increased pattern of B lines. There's some A lines there, and you do have pleural sliding, and you have this seashore sign. So this we know is a lung problem. And in this case, we had a pneumothorax that we had to address because this baby was clinically very symptomatic. And it was actually a tension. So we put in a chest drain. Patient improved quite significantly with putting the chest drain in, but we were transferring for an hour away. Whereas in a neonatal unit, you maybe would have said, hold on a minute, let's see after the draining if this baby improves. In transport, you want to pay it on the safer side. So we decided to intubate that patient just for safety to be able to get to where we were going, and the transfer went without any issues. So I would like to talk about two uses that have been described there and algorithms. So the first one would be the Blue protocol. This one, strictly speaking, has been validated in adults. We don't have it validated for children or pediatrics, but essentially relies on lung sliding present, abolished, A lines, B lines, and with just these three signs, you can get a bit of a pathophysiological assessment of that patient to give you a bit of an idea where the shots are going. One that is definitely more adapted to neonates, and some of you might be familiar with it, is the LUS, or lung ultrasound in postnatal respiratory distress. And this is very similar to the Blue that I just showed you before. And it's the same. Lung sliding, A lines present, absent, B lines. And with this, you can quickly have a big understanding of what's going on and try and see what's the syndrome or what's the diagnosis behind that patient. So going now to the second case, we get a referral also for a term male, 4.5 hours old. In this case, he's in an LNU. On a CPAP of 90% oxygen, they said that the baby was relatively okay, but the SATs were definitely not meeting. They said that the baby actually on the CPAP seemed to be worse than before, so they thought that they would try high flow to see if it was more comfortable. And actually the baby collapsed on the high flow, so they decided to intubate and start on 100% oxygen. They did mention that they suspected that this was a meconium aspiration because there was some presence of meconium at delivery. And however, the SATs were really low in the 70s and 80s. And there was moments where there was a bit of a pre-post SATs different, but not all the time. And they did a chest x-ray that they reported as normal. So some things don't quite add up there, but this is what we would qualify as an immediate dispatch, which are criteria universal for England. And it essentially means that you need to get the door as soon as possible, usually within an hour. Well, within an hour, because if you think about it, you need to find a bed, get the ambulance ready, make sure that all the equipment is sorted. So an hour can go really, really fast when you're taking a referral. So the diagnosis at that point was this could be PPHN, and the recommendations were made to start sedation, paralysis, and consider the use of inotropes to try and achieve a better blood pressure, to try and manage this patient more effectively. When we got there, baby was on relatively high pressures and settings on the ventilation, an FiO2 of 100%, and we still had managed to change the SATs there. There were no murmurs, and the femorals were actually felt bilaterally. But we did an arterial gas that showed that this patient was quite significantly hyperventilated, but the oxygenation was really poor and had some raised lactate as well with an OI of 45. So we thought, okay, we're dealing with PPHN with a baby that was reported as meconium, although the X-ray isn't normal. It was normal, but sometimes that can happen. So let's start some nitric and let's put some lines because this baby is clearly very sick. And then the question arose, should we use Prostin in this baby? Because actually, we're 100%. Yes, it's true that the baby was uncomfortable on the CPAP, but they said that before the CPAP, there was no increased work of breathing, and the baby was actually with SATs that were also borderline, and that's what triggered the admission to the neonatal unit. So we think, is this a cardiac patient? So we did a really quick echo in that case, and what we could really see was this extremely small right ventricle, really dilated right atrium, and the objective of POCUS isn't to look at congenital heart disease, but there's something that's clearly not right with that heart. And especially if you take into consideration all the other signs that you've been described, you think, right, this is actually a cardiac baby. I need a cardiac center. So in our case, we spoke to cardiology and we changed the destination to a cardiac center rather than the closest tertiary center. We thought it was more appropriate to go to the cardiac center. Whilst we were trying to rearrange that, the baby had a sudden deterioration further, and we were actually able to start prosting, and there was little else that we could do for that patient where we were, and we were quite far from a cardiac center, so we decided to opt for a strategy of scoop and run. And actually, after that, the transfer didn't go with too many issues. So this brings me to talk about Echo, POCUS, TNE. There's many names out there, but it's a quick assessment at the end of the day, and you can look at contractility, volume, pericardial effusion, sometimes PDA if you think that that is a contributing factor, but it may not be the main focus in transporting, and if you have pulmonary hypertension. What I definitely wouldn't do is, I am not there to do 20-30 minutes to see what's going wrong with that heart, but you can say, oof, this is definitely not normal, I need a cardiologist, and that's what we saw in the previous case. And I know that sometimes what you can do is just a 4-chamber view, but I really like this. It's called the golden spiral. And it's really, you can do it in less than 5 minutes. You go really quickly through the different assessments, and you will have a relatively good idea of, is this heart okay? The other one that I have to mention is the cause, which has been validated in adults. And I know that there's been a lot of people, and it's coming quite strongly as well. But essentially, it's the use of an ultrasound when you have a baby that's arrested. And the first thing that I want to leave clear is that ultrasound doesn't substitute your A, B, C, your normal CPR, your normal NLS. So you do all this. And when things are not going the way you would like it to go, it's when you say, get me an ultrasound machine. Or if you have somebody that's actually free, and because sometimes when there's a baby that's arrested, there are a lot of hands there. So if somebody has the expertise, they can do a quick assessment whilst all the resuscitation is taking place. And what you're looking is this heart normal? Is this car a bit small or squashed, so I might need volume and I need to address the hypovolemia? Is there a tamponade? Or is the right side so dilated that I should suspect a pulmonary embolus? So it's more or less going to assess the famous 4H's, 4T's to see what's going on with that patient. And the other one that has also been validated in adults is the rush. And essentially what it does is it looks at the pump. Is the heart contractility okay? Do you have any free fluid somewhere? So we look at if there's any tank that's filled up with fluid, and we also look at the pump. So a coarctation of the aorta, or if there's been an embolism, if there's a thrombovenous there. So now moving to the third case. This is a baby girl, 25-weeker, now old, in a special care unit, 600 grams, that actually went for CAT1 due to a maternal APH. Baby was born in really poor condition and needed 2 rounds of CPR. The team there is overly trying to stabilize that patient. They've put ET tube in place, and they're at the moment placing lines. And at around 30 minutes, we had a gas that was really not good for this patient, really acidotic, with quite a high lactate as well. So our recommendation was like, put central lines, go for it, because this baby is clearly very unwell. And this would also qualify for an immediate dispatch, so we blew lit to that baby. When we got there, it was half an hour after we had the referral. They had managed to put the baby on the ventilator in reasonable settings. An arterial gas was repeated. And I don't know if you've noticed the difference between the cord gases, where the HB was 140 and this arterial gas is now 90. The baby's still quite acidotic. This gas is suboptimal, and the blood pressure is also suboptimal in this case. And actually, when we got there, they had just intubated and they had just put lines in, and they were like, okay, we are going to request x-rays. But we know by experience that even in the quickest of scenarios, it takes at least an hour to get an x-ray. So here's where we brought the ultrasound machine. This is not the image of the patient, but we checked for the tube position. Is this baby intubated or not? And what you're looking to do is you do a transversal cut of your trachea, or even in your parasternal notch. and you look, do I have a single echogenic bubble kind of thing, where the image that would be on your right, and with a little double rim there, and that's the tube? Or do I have two bubbles there? The second bubble would be the esophagus, which is virtually collapsed. So if you have that really present, your tube's definitely not in the right place, and you will want to reposition it. Sometimes, since in neonates we use nasogastric tubes, we can see a really, really small tube in there, but it's definitely not the size of an ET tube. And the other thing that you would do is that you would check if there's pleural sliding or not. If you have bilateral pleural sliding, I wouldn't suggest doing a full assessment. You can do it, but it's a bit more complex to see exactly where the tube is. But if you have pleural sliding, you know that it's not terribly in the wrong place. So that's what we did with this patient, and the tube was in the right place or acceptable for the transfer purposes. So whilst we were waiting for the x-ray, we were happy with the positioning. And the other thing that we did is that we looked for a line. Is my UVC, is my UAC in the right place? Because this baby is suboptimal. We need to ideally start inotropes potentially. We want to give volume, is really sick. So I want to make sure that these lines are in place. I don't want to wait the hour for me to make sure that the UVC is in the right place. So we scanned and we saw that the UVC was just in the ductus venosus, perfect for transferring that child. And we then decided to use all the infusions through that line. Finally, the thing that worried us the most was this HB drop that actually was systematic in the gases. So we thought, we definitely need to scan this baby's brain. Has there been blood somewhere? And what we could see was a really substantial grade 4 IVH that was having quite a compromise already in that baby. So at that point, we were having discussions with the local team, with the tertiary center that had accepted, and they were keen to take this baby. Although from a transfer point of view, we know that when we transfer children, there's a really significant risk of IVH. And when they've had a significant IVH, this might become much worse. So for us was a bit of let's have a careful consideration. We'll try and stabilize this patient because at the moment, the baby is not suitable for transferring, but we need to be cautious. So at 5 hours of age, the blood pressure is still suboptimal. We've given a blood transfusion. We've given inotropes. The HB recovered to 140, but then when we repeated again, the HB dropped 90, 95. So it had dropped subsequently. We did again a head scan because situation had changed. And in that point, we had a bilateral grade 4 IVH with the first one doing a midline shift. And there was also the presence of a subdural hematoma that we hadn't seen before. So given the context that the baby was extremely sick and the prognosis was extremely poor, after conversations with the family and the local team, we felt that it was more appropriate to reorientate care rather than cause maternal separation, because we were going an hour and a half away and the baby could have even died in the same transfer. So I would like to bring here what we call the SAFER, that is coming in quite strongly. It hasn't been fully validated yet, but I think it's a very good pragmatic assessment to a baby that's crashing. And it's with the single probe, you do a 5-minute assessment and you look, how's your heart? How's your lung? How's the aorta? How's the abdomen? And do you have a severe IVH? So all those lesions that are life-threatening, to be able to discard it, pneumothorax, pleural effusion, tamponade. And in this case, it was quite useful because we had a crashing neonate and we definitely had a massive IVH that then led us to a change in the management of our patient. So this is also the crashing neonate, which is where the SAFER kind of got the idea, and it's a bit in parallel. And rather than doing this structured assessment, it's what's going wrong with your patient. Let's try and focus on that and let's try and address that. So it's not going through all the 6 items, it's just finding which is the most appropriate for your patient. So now going to the next case. In this case, we have a late preterm and now old in a special care unit, IUGR, on a CPAP, relatively okay, comfortable with an FiO2 that was acceptable, with gases that were okay, but actually the baby had been hypoglycemic, been admitted to the unit with 2 glucoboosts, still hypoglycemic, and they had tried 12 times for a cannula, completely unsuccessful. The anesthetist, the 2 consultants, the pediatric registrar, and a UVC. So they hadn't gotten access for their baby, and they still hadn't been able to address the sugars. So we dispatched, and when we got there, they hadn't been able to get an access yet. and the sugars were still suboptimal. So here's what would come into place, what I call procedures POCUS. And it's the use of the ultrasound machine to try and see, one, do I have a vessel that I can cannulate? Two, guide my procedure whilst I'm cannulating the vessel. And I'm not going to go into too much detail because it would be quite extensive. But essentially what you do is, in this case, you do a short axis, you put your probe on the patient, you try and find the best vessel, you will see it as an anechoic bubble in your field of view, and you will try and get your cannula at 30 degrees, and you will stab where your probe is until you see the shaft. The shaft is something quite echogenic, and you thread the needle. So you kind of move your ultrasound a bit further, and you keep introducing your needle, and you keep chasing one another until you see that that echogenic little bubble is in your anechoic structure that was the vessel, and you get some flushback. You don't always necessarily need to get flushback in neonates. It can sometimes be complicated. What you can do is inject some saline, and if you see it moving in the vessel, you know that it's in the right place. So this is what we did in this case. We were able to get a cannula really quickly. We gave a glucose bolus and we started an infusion, and our glucose was fine. So we were able to transfer without any issues. So procedures POCUS isn't only in looking at the vessels. You can look at, as we saw before, to check what's your tube position. You can use it to guide pleural drains. You can use it to put central and peripheral lines to check for UVC and UAC positioning. And you can also use it to guide your pericardial drains or your abdominal drains. So now going to the fifth case, we have a extremely preterm infant, 27 weeks, 5 days old, in a district general, good weight, was on CPAP, doing nicely, no concerns except overnight the baby collapsed. They needed to intubate quite quickly, trying to ventilate with high pressures, 100% oxygen, and with gases that are very suboptimal, really acidotic, really struggling to oxygenate, struggling to ventilate that patient. They have tried to start inotropes, and they've given 2 fluid boluses. Despite that, the blood pressure probably is a bit borderline. And what they mentioned was that the abdomen was very distended. So they did an X-ray and they had a gasless abdomen. Curiously, just as a mention, they said, oh, the UVC fell out and we replaced it, now it's in a good position. So they were working with the diagnosis of NEC. But when we were told that the UVC had been fallen out and the X-ray showed the gasless abdomen, we didn't know if that was truly NEC. So we dispatched there. This would also qualify for an immediate dispatch. And when we got there, the baby was ventilated on 6 mils per kilo, but not even achieving the pressures that were limited, in 100% oxygen, with sats that were dropping down, and the blood pressure was dropping down. So we optimized a bit the inotropes whilst we were doing a quick assessment of the heart to see if there was something wrong. And then we decided that we needed to scan that abdomen. And what we could see was that there was all this anechoic fluid in the abdomen, and also the anechoic fluid was also present in the chest. So here we were working with a diagnosis of a PN extravasation. And what we could see is here you have the Medusa sign in your pleural effusion there. This is the images from the machine that we are currently using. So in that context, we did the paracentesis. This baby was clinically unwell, unable to ventilate, so it was clinically compromising. 20 mils per kilo, and at that time, just to ensure that the blood pressure, knowing that there could be a bit of a fluid shift, we gave a bolus of 10 mils per kilo. We removed the UVC and we put a long line to make sure that we had a good access for those inotropes and that they were going in the right place. With that, the patient stabilized and transferred without issues. Some of you might be wondering, why didn't I put a chest drain as well? And this is what we call, or has been called in literature, pleural ascites. So when you have a really big ascites that's compressing, you can have an escape of that fluid to the pleural effusion. And usually when you drain the abdomen, that also improves. And actually that was the case when we got to the center. So this brings me to talk about abdominal POCUS, and it can be used for UVC positioning. It's really useful when you suspect that there might be a PN extravasation, and it's the clinic typical story is baby there was okay, collapsed, and there's always been a problem with the line. And to look at the ascites from other causes, the hydrops, for example, and to guide your paracentesis. So you want to make sure that you find the deepest pocket and where you don't have the epigastric vessels, which are very easy to identify with a bit of color. and you can do an NEC assessment. But to be honest, I would only use it if you suspected that baby's perforated or you need to go to a surgical center, but you're not quite sure, and the x-rays are not clear either, because it does require a bit of more expertise. So I wouldn't suggest doing it always on transport. So to take home, POCUS is a portable, quick, non-invasive, non-radiated method. It can greatly impact management and destination. In my experience, it doesn't prolong transport time excessively. 3 to 5 minutes in the grand scheme of things isn't excessive for me. And POCUS has a big learning curve, but sometimes can be used with a basic level, trained in a reasonable amount of time. And it can also be taught to non-medical staff quite effectively. I do realize that I haven't talked about how to implement it in the transport teams, and it might be some of you are interested in that. Haven't talked about governance. We can talk about that now, but I really wanted to focus on these concepts. So thank you, everybody, for listening.
Thank you, Ben. That was really fantastic, and a whistle-stop tour of POCUS and transport. So thanks so much for those illustrative cases. We're going to open up the floor to some questions. Yeah, so there's a question here about probes, and I think one of your initial slides showed the probes used, didn't you? So I think you mentioned you used a laptop style probe, ultrasound machine.
Yeah, so in our case, we use a laptop style just because it has the middle ground of the two. It has reasonable good quality of image. It has a couple of hours of battery life. It can withstand bashes. It's durable. It's been tested. The US use it in the military, so if they use it, I'm pretty certain that my team can't destroy it as much as a military man. And that for us was also the reasonable place cost as well. It is a bit more expensive than the handheld probe, but it is also cheaper than the other ones.
And which make and model do you use?
So in our case, we use the Sonosite Edge 2, which would be a bit of an upgrade for the M Turbo. There might be others out there, and I'm not paid by Sonosite, and I do suggest that you speak to different reps because there might be other solutions out there. Did you want me to talk about probes as well, or was it more the ultrasound machine itself?
Yeah, so that was about the machine, but if you've got any insights on the probes, that would be fantastic.
So from my opinion, you can do everything that you definitely need on transport with a phased array and a linear. You can do head scans, you can do a quick echoes. You can use a linear for that as well, but it may, if you have a really bad window or an extreme baby, you might be a bit more compromised for that. And linear is definitely very useful in lungs, to look for vessels, to assess superficial structures. So for me, the curved linear may not be very important. You can use it for some abdominal POCUS when you have some doubts in achieving the UVC views. You can use it, but if I'm honest, any hospital will have a curved linear. They might not have a linear probe, and they may not have a neonatal acceptable phased array either.
Thanks, Ben. It was an excellent presentation. Really enjoyed, and all the cases were brilliant. I'll go to the next question. The question is about the governance. What is your experience in storing the images and sharing the images?
So what I can talk is about our perspective, and it might be a bit different because in our case, the transport team, although it's subscribed to a trust, is in a completely different building. It's completely separate from a hospital, whereas I know that other transport teams are completely linked to a hospital, and that might be a bit easier there. So from our point of view, we could not get our system to connect directly to PACS through Wi-Fi. So that was a bit of an impediment. And what we need to do to download the images ideally is to put a pen drive in. And I know that that cannot always be very safe, especially from a governance point of view. So what we usually do is this is a functional assessment. This is POCUS. This is not to do a quick assessment that's going to change all the outcome of the baby. So sometimes we may store images if we want to discuss it with the consultant later, if we want to peer review it, but we don't do permanent storage because we understand that in those circumstances, it's like if you had a stethoscope and you're using the ultrasound instead of the stethoscope. If you definitely want to save images, you might be able to, or save images to upload and share with somebody else. What you can do is use the unit machine. They might be able to have one that's acceptable for you and be able to upload the images to PACS and send them across to another trust. What you can do as well is, as long as you don't have any patient confidential information, you can, as you've seen there, you can do some photos, you can do some videos, making sure as well, because sometimes when you do videos, and that's why I haven't shared a few of them, you do disclose patient information. So those, you definitely need to delete them. And what we do is that we tend to use phones that are accepted to send images for the transport purposes. In terms of reviewing images or the governance of that, so we have trainees that have had training, have had an assessment within the transport team and have been signed off for specific assessments. So it's not people that we do not know their level of skill. We know their level of skill, and not all our clinicians are able to do it. And at the same time, we make sure that this is peer reviewed by people that have adequate accreditation as well. So if they're going to do something with the images they've seen, they need to discuss those images with somebody that's been accredited. And it might be that that person has already been accredited, so that's absolutely acceptable as well. I hope this tackled a bit of the concerns around governance.
Yeah, thanks, Ben. Yeah, it does. Yeah, it does. I have a question on that. Do you store the images in your local machine, in the scanning machine, what you take in the transport? Do you store the images there for reviewing with the peer review?
We can store them. There's not a lot of capacity in
Okay.
especially if you start doing videos, that will go in really short amount of time. So that's why we are not able to store them quite effectively, unfortunately. And we haven't had the right solution. I'd be happy to hear if somebody's thinking of other solutions or they found something that works for them. And I'm happy to bring the ideas on board.
Thank you.
Thank you, Ben. So thanks so much for sharing your practice. I think in terms of, for example, with the case of the baby with a pneumothorax, I was just curious as to whether the team waited for a chest X-ray before acting on the features of a pneumothorax based on the lung ultrasound, or was this person accredited and trained to be able to diagnose a pneumothorax on ultrasound?
So yes, the answer is yes. I actually did. All the images that you've seen, some of them I have done. So I did do those images myself. I put a test in without waiting for an X-ray. It's like if you use a cold light at the end of the day. Would somebody wait for an X-ray when you've done a cold light? I'm pretty sure none of you would do, especially if this baby is compromised and it looks like a tension pneumothorax. Because we know that when the pneumothorax is present anterior, lateral, and posterior, that is a tension. There's no question there, so you need to drain that. And we put the drain in, and actually we did request the X-ray the moment we were scanning, and the X-ray came once the chest drain had already been put in. So that gives you a bit of an idea of how long it took to get the X-ray.
Absolutely. So here you based the intervention on baby's clinical features, the SATs, the ventilation, your lung ultrasound findings, and then the baby improved and you subsequently got the X-ray.
Yeah, absolutely.
Fantastic. And then we had another question in the chat about which probe you use for IV access.
So you would use the hockey stick, the linear probe, ideally.
Yeah.
Thank you. Ben, I have a question. For example, one of the cases you nicely did the focus of the heart, abdomen, head. How long does it take, the time scale? Because I know, if you want to get X-ray done, as you said, it can, even the quickest, it may take up to 20 to 30 minutes, and some units, it can take up to an hour. So in roughly, in your experience, if you want a quick focus in a baby who's very sick, needing a lot of oxygen or a lot of inotropic support, and you don't know what's underlying pathology is, what is your time scale, and how quickly you can do the whole focus?
So it's a bit of a complex question because it depends on the skill of the practitioner and their trust in their own skills. So if you have experience with POCUS, you have used it practically, you can do a full head-to-toe assessment in less than 5 minutes. And usually in 2 or 3 minutes, you have a pretty good idea of what's going on there. And it depends. So if you go for the safer, it's going to be more or less 5 minutes. If you do more of a crashing neonate and you focus your assessments, that will be a bit quicker. So it depends on what your questions are, where you're at, and trying to understand the algorithms and using one or the other depending on your clinical needs. And if you have a lot of experience in a very short amount of time, you will have the answers.
Thanks, Ben. That's very useful. 5-10 minutes, you get an understanding what's happening with his baby's heart, lung, or abdomen. What's the issue? I think that's a short amount of time. You do get like a significant amount of information, and that will tailor your further management. Thank you. I'll go to the next question. The question is, what accreditation the team member have got?
So unfortunately in the UK, you don't have any neonatal accreditation. I know it's a project that's being worked on and hopefully it will be achieved soon enough. It depends really on the clinician. If you want a UK-based accreditation, you can use the CACTUS courses. They are pediatric based, but they do give you accreditation. And if I'm 100% on it, apart from cranial ultrasound, and I can talk a bit about different courses there, the CACTUS is more or less equivalent for neonates, and they do also look into some of the pathology for neonates. There's the PHYSIC as well. You can go for the 2-year accreditation for TNE, but that is quite extensive and quite long, and it's probably not the scope of POCUS. It's more the scope of somebody with special interest in cardiology, and that you are doing echoes, full-blown echoes, 20, 30 minutes, a good assessment rather than a clinical question, functional assessment. From a head scan point of view, there's the European US brain team. They do really nice courses and they are really useful and bring a lot of insight. And there are other countries that do have neonatal accredited courses. So for example, in my case, in Catalonia, in Barcelona, we have courses that are accredited for lung ultrasound, for echo, and also for cranial ultrasound. So these courses are valid at the European level. I know that the UK is not Europe anymore, so that can sometimes clash in the terms of governance purposes. And that's why I would suggest potentially looking into the CACTUS course.
Thank you, Ben. Thanks for that. That's useful information. And just to add on to that, like in NeoFOCUS UK, we are also working to develop some accreditation for a POCUS in the crashing neonate. I think still the work in progress. Hopefully by end of this or early next year, we should have some kind of accreditation for neonatal POCUS. Watch the space.
Definitely looking forward to that.
Yeah. There's something by Omaima that Polish Radiology Society has some consolidated training, which is developed by a Polish team, I think, yeah. And it is funded by the NHS. So interesting. Okay. Just put some links as well on the Q&A if anyone is interested to see.
Thank you. That sounds interesting, and I'll definitely take a look at that.
Any other questions? Anyone has anything to ask? Ben, if we're still waiting for questions, so I can ask another question to you. I'm quite interested in POCUS for ET tube. For the umbilical lines or the long lines, what normally we do is we can do the POCUS, and sometimes if we can't see a tip clearly, we flush some cell line to identify exactly the tip. I'm not very experienced in ETT POCUS. How do you identify the tip position? I know you did explain, but I still have some questions around that. How do you find out exactly the tip is in the ETT?
So looking at the tip is exactly where you want to know the tip is a bit more complex. You need to have POCUS skills, but also a bit of echo skills. So what you would try and do is you do a longitudinal cut, linear probe or phased array. Both can work. It depends a bit on the size of your patient. And what you would see is that you see the trachea quite nicely. And you get like the double rim, like if it was a cannula in a vessel or like the UVC, and you can more or less see where the tip of the tube is. You want to make sure that the tip is above the right pulmonary artery and definitely above the aortic arch. So that will give you a bit of an idea of where the tip is. That's for the good tip assessment. But if you just need a quick answer that I don't need this tube to be in a prime position, I need this tube to be in and manageable for that baby, you can rely on, is the tube in the trachea or not? That's really quick. You don't need a lot of training to identify that. And then, is there bilateral pleural sliding? If there's bilateral pleural sliding, the tube is, at least it's somewhere that you are ventilating both lungs equally.
Excellent. Thank you, Ben. That's useful.
There's a question about the SAFER protocol, and just wondering if you change probes during the different views for that.
Yeah, give me a second, I'll bring it up. So no, the answer is no, you do not change probes for the SAFER protocol. If your baby is arrested or crashing, you want to do it really quick. And depending on your needs, as I said before, you can use a linear probe, you can use a phased array, and you can even use the curved linear. You will have suboptimal images, but our point there isn't to get quality images, is to get, this baby is crashing, I need to do something now. So you can't spend time in changing your probes, sorting things out. So phased array or linear is my go-to probes to do a SAFER protocol, because look, a tamponade, you can do an intercostal scan of the heart. You will see if there's a tamponade or not. Lungs, great. You can also see if there's a pleural effusion or tension pneumothorax with a phased array. You just need a bit more experience and it's a bit more angled. Aorta, you can see it with the linear probe. You will see if there's an occlusion, if there's no flow going through the aorta, or if it's really accelerated. An IVH, if it's important, even if the baby has a small window, you will have a view of the center. So if it's a significant IVH, you would see it. And free fluid in the abdomen. Actually, the images that I showed you of the abdomen, that was done all with the linear probe.
Okay, fantastic. Thank you, Ben. I had a practical question about storage of the ultrasound machine on the ambulance. So presumably, is it like does it tuck into a little suitcase that you can take with you?
Yeah, so in our case, we have a purpose suitcase for that, and it's probably the size of a 20-liter bag. So to give people the idea, it's half the size of what you're allowed in a carry-on kind of thing. And we are able to store that there. We have gel probes. We even have some covers for the probes if we need to do anything sterile. And we have our 2 probes and the charging cable there. And it fits quite nicely. And it's brought by the actual house itself. So we didn't need to kind of customize a bag that sometimes we need to do in transport. And it fits quite nicely in one of our cupboards.
Fantastic. Thank you.
Any other questions? Anyone has any other questions for Ben? Okay. Jean, shall we close the meeting? Like, if there's no other questions, yeah.
Thank you so very much, Ben, for sharing your valuable experience on the use of POCUS and transport. I think you've really illustrated the use of POCUS in lots of different modalities in babies with different presentations. Thank you so much for your time and coming to speak to us.
Thank you for having me. And if people have questions, feel free to contact me. I'll be more than happy to answer them.
Thank you, Ben. It was fantastic. Really enjoyed all the cases were really interesting. Thank you.
Thank you.
Thanks, everyone.
Please complete the survey online and you'll receive an attendance certificate following that. Thank you.
Thank you. Thanks. Bye-bye.
Bye.
Bye-bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.